Welcome to the 2020 Vermont Statewide EMS Protocol Update for the Advanced Emergency Medical Technician, AEMT, Cardiac Protocols. Syncope. We have added a new adult and pediatric syncope protocol. Syncope is heralded by both loss of consciousness and postural tone and resolves spontaneously without medical interventions. Syncope typically is both abrupt in onset and resolves quickly. EMS providers may find the patient awake and alert on initial evaluation. Pre-syncope is defined as the prodromal symptoms of syncope. It usually lasts for seconds to minutes and may be described by the patient as nearly blacking out or nearly fainting. Inclusion criteria for syncope include an abrupt loss of consciousness with loss of postural tone or prodromal symptoms of syncope. Exclusion criteria include conditions other than these, including patients with an alternate and obvious loss of consciousness, such as head trauma, or patients with ongoing mental status changes or coma that does not resolve quickly. These patients should be treated per the Altered Mental Status Guideline. Treatment of syncope is broad and should be directed at abnormalities discovered in the physical exam. Follow routine patient care. Administer oxygen to target 94 to 98% oxygen saturation. Attempt to determine the cause of syncope by history and the following interventions. Obtain and transmit a 12-lead ECG. Check a blood glucose level and treat hypoglycemia as indicated. Patients with ongoing mental status changes or coma likely did not have a simple syncope episode and should be treated per the Altered Mental Status Protocol. Perform a stroke screening exam and follow the stroke protocol if positive. Assess for trauma, either as the cause of syncope or as a consequence of the syncopal event. Prevent and treat for shock and consider an ALS intercept if indicated. AEMTs should consider establishing IV access and administering a fluid bolus if indicated. For example, if the patient appears dehydrated or in shock. By being most proximate to the scene and to the patient's presentation, EMS providers are commonly in a unique position to identify the cause of syncope. Consideration of potential causes, ongoing monitoring of vitals and cardiac rhythm, as well as detailed exam and history are essential pieces of information to pass on to hospital providers. All patients suffering from syncope deserve hospital-level evaluation, even if they appear normal with few complaints on scene. Acute coronary syndrome, adult. Oxygen administration guidelines were changed slightly in the acute coronary syndrome protocol, with emphasis on avoiding hyperoxia and titrating oxygen to the least amount necessary to achieve a target oxygen saturation of 94 to 98%. ECG acquisition is not changed, but just a reminder. If your agency does not currently have the capacity to transmit ECGs to the receiving emergency department, you are strongly encouraged to work on obtaining this technology. A 12-lead ECG should be obtained in all patients with the following signs and symptoms: chest, jaw, or arm discomfort, shortness of breath, epigastric discomfort, syncope, general malaise or palpitations, self-administered nitroglycerin, or after sudden cardiac arrest with return of cardiac activity. High-performance CPR has replaced our old cardiac arrest protocol. In order to use high-performance CPR, your EMS agency and individual providers must first complete a full Resuscitation Academy, or RA, offered by Vermont EMS. We've been offering this training across the state for the last 2 years. If you have not yet completed it, please contact Vermont EMS and schedule a training at your agency. Follow the 2018 cardiac arrest protocol until your agency has completed this training. Let's review the flow sheet. Establish unresponsiveness and start CPR upon arrival. Apply the AED as soon as possible and analyze. High-performance CPR focuses on high-quality, minimally interrupted compressions in 2-minute cycles. Chest compressions are interrupted only for rhythm, pulse check, and defibrillation as indicated. Interruptions to compressions should never exceed 10 seconds. BVM ventilations are interposed into continuous chest compressions with 1 breath every 10 compressions. If resource limited, apply high-flow oxygen via NRB for passive ventilation, but use BVM as soon as more help arrives. For arrests of non-cardiac etiology, including respiratory and trauma arrests, use BVM ventilation. Note that during the initial 4 cycles of CPR, the focus is on high-quality, minimally interrupted compression. Additional instructions for AEMTs. Administer epinephrine every other cycle up to a maximum of 3 milligrams. Delay placement of an advanced airway if possible until after completion of the first 4 cycles of compressions. It's not complicated, but it's not easy either. We'll review the protocol now, but remember the full RA training is required to perform the skill properly. True high-performance CPR will lead to marked improvements in the survival of pre-hospital cardiac arrest. Here are the EMT standing orders for adult cardiac arrest. Initiate immediate high-performance CPR with minimal interruptions. Use a metronome if possible. Apply the AED and use as soon as possible. Continue 2-minute cycles of uninterrupted chest compressions followed by AED analysis and shock if indicated for 4 cycles. Place an oral or nasal airway. During the first 4 cycles, the focus is on high-quality, minimally interrupted chest compressions. Ventilation oxygenation options during the first 4 cycles should be by BVM ventilation, 1 breath every 10 chest compressions during recoil. Or, if in a resource-limited situation, apply high-flow oxygen via NRB, but use BVM as soon as more help arrives. After 4 cycles, continue 2-minute cycles of uninterrupted chest compressions. If passive ventilation was used, switch to BVM ventilation. Notice that we have eliminated the 5-shock rule and instead encourage EMS practitioners to remain on scene providing high-performance CPR for 20 minutes prior to assessing for possible termination of resuscitation. Studies have shown that EMS systems that stay on scene longer have both higher rates of return of spontaneous circulation and higher rates of termination of resuscitation. In addition, this change aligns the cardiac arrest protocol with our existing resuscitation initiation and termination protocol. Transport is indicated prior to 20 minutes if return of spontaneous circulation is obtained. Patients who regain return of spontaneous circulation or those with airway obstruction should be considered for immediate transport. If the cardiac arrest is due to suspected opioid overdose, it is reasonable to administer 4 milligrams of intranasal naloxone. There are some important changes to the AEMT cardiac arrest protocol. First of all, remember, the top priority are continuous, high-quality, minimally interrupted CPR compressions. Do not interrupt chest compressions for advanced airway, IV-IO placement, or epinephrine administration if possible. During the first 4 2-minute-long cycles of CPR, consider advanced airway only if airway patency cannot be maintained using basic maneuvers and adjuncts. Let's talk about IV versus IO access. Recent evidence suggests that IV access is preferred to IO access in cardiac arrest. This is likely because medications given through the anterior tibial IO do not circulate well to the heart. New guidance for the AEMT is to first try and establish IV access. If unable to establish IV access, then establish IO access. However, if establishing IO access, the proximal humeral location is preferred to the anterior tibial location, as it is believed that medications administered through the proximal humeral IO will be more likely to reach the heart. Note that epinephrine can be administered every other cycle, but that the maximum dose is 3 milligrams or 3 1 milligram administrations. Recent evidence suggests that higher doses of epinephrine in cardiac arrest are associated with vasoconstriction of blood flow to the brain, leading to poor neurologic outcomes. After 4 cycles of high-performance CPR, or 8 minutes, consider placement of a supraglottic airway without interrupting chest compressions. Finally, although naloxone generally has no role in the management of cardiac arrest, if the cardiac arrest is due to suspected opioid overdose, administer naloxone 2 milligrams IV or IO. It is sometimes difficult to distinguish between true cardiac arrest and a severely depressed CNS condition associated with opioid overdose. Administration of naloxone in cardiac arrest with suspected opioid overdose may reverse CNS depression if the patient was not in true arrest. Case reports exist of patients who were thought to be in arrest but responded and awakened after naloxone administration. Similar changes using high-performance CPR were made to the pediatric cardiac arrest protocol. We will be sponsoring regional train-the-trainer classes for pediatric high-performance CPR in the coming year, and your agency should practice the techniques. We recommend that both adult and pediatric high-performance CPR be reviewed on at least a quarterly basis. Keeping these skills sharp will go a long way to improving survival rates of victims of sudden out-of-hospital cardiac arrest. Waveform capnography. Waveform capnography replaces quantitative waveform capnography protocol. Both AEMTs and paramedics are now instructed to monitor both the waveform morphology and the end-tidal CO2 levels of capnography. Indications for use of waveform capnography for the AEMT include confirmation of supraglottic airway placement and monitoring ventilation status, including BVM ventilation, CPAP, respiratory distress, altered mental status, and any invasive procedure or blind airway device. Waveform capnography is also helpful for monitoring CPR quality and for signs of return of spontaneous circulation in cardiac arrest patients. Monitor both the waveform morphology and end-tidal CO2 levels by capnography. Remember, high levels of CO2 greater than 45 can indicate hypoventilation or CO2 retention, and low levels of CO2 less than 25 can indicate hyperventilation or a low perfusion status such as shock, pulmonary embolus, or sepsis. For patients with traumatic brain injury, it is critical to avoid hyperventilation. Maintain end-tidal CO2 between 35 to 45 with a target of 40. Waveform capnography can be helpful in cardiac arrest. In low pulmonary blood flow states such as cardiac arrest, the primary determinant of waveform capnography is blood flow. Capnography levels are a good indicator of CPR quality. If capnography levels are dropping, the CPR quality may be poor. Consider changing chest compressions. A sudden rise in end-tidal CO2 level to 40 or greater indicates substantial improvement in blood flow and likely return of spontaneous circulation. An end-tidal CO2 level of 10 or less measured 20 minutes after the initiation of advanced cardiac life support accurately predicts death in patients with cardiac arrest. Both AEMTs and paramedics may now use waveform capnography to monitor the response to CPR. Congestive heart failure or pulmonary edema. Dosing instructions titrated according to blood pressure range were added for the AEMT for nitroglycerin administration. Nitroglycerin is the first-line medication for treating an acute CHF exacerbation. It reduces both preload and afterload on the heart, leading to improved cardiac output and less pulmonary resistance. Establish IV access prior to nitroglycerin administration, as it can sometimes cause hypotension that requires treatment with a fluid bolus. Contact medical direction to consider nitroglycerin. For a systolic blood pressure of 140 to 160, administer nitroglycerin 0.4 mg sublingual. For a pressure of 160 to 200, administer 0.8 mg sublingual. And for a pressure greater than 200, administer 1.2 mg sublingual, or 3 tabs or sprays. The above doses may be repeated every 5 minutes until symptomatic improvement, or systolic blood pressure is 140 or less. CPAP continues to be an excellent treatment option in acute CHF. The maximum pressure support for CPAP was changed from 10 to a range of 10 to 15. Start at a pressure support of 10, but titrate up to 15 as needed. Post-resuscitative care. Out-of-hospital cardiac arrest in the U.S. has a mortality rate greater than 90% and results in excess of 300,000 deaths per year. Many of those who do survive suffer significant neurologic morbidity. The goal is to optimize neurologic and other function following return of spontaneous circulation. It is important to optimize both ventilation and oxygenation and to monitor the patient closely for recurrence of cardiac arrest. The EMT section was updated to clarify goals around oxygen administration and ventilation. Hyperventilation is a significant cause of hypotension and recurrence of cardiac arrest in the post-resuscitation phase and must be avoided. However, most patients immediately post-resuscitation will require ventilatory assistance. The initial ventilation rate should be no faster than 10 to 12 breaths per minute. Administer oxygen as appropriate with a target of achieving 94 to 98% oxygen saturation. Use the minimum amount of oxygen necessary to maintain this target range. Do not hyperoxygenate. The condition of post-resuscitation patients fluctuates rapidly and continuously, and they require close monitoring. A significant percentage of post-resuscitation patients will rearrest. In addition, A moderate number of post-resuscitation patients may have evidence of ST elevation MI and EKG. Therefore, it is important to acquire and transmit a 12-lead ECG if possible. Titrate the ventilation rate to waveform capnography of 35 to 40 and oxygen saturation to 94 to 98%. If an advanced airway is present, the initial ventilation rate is 6 to 10 breaths per minute. Similar changes apply to the pediatric post-resuscitation care protocol. The initial ventilation rate in a child is 12 to 20 breaths per minute. If an advanced airway is present, the ventilation rate is 8 to 10 breaths per minute. Titrate the ventilation rate to waveform capnography of 35 to 40. When feasible, titrate the oxygen to the minimum necessary to achieve oxygen saturation of 94 to 98%. Maintain systolic blood pressure 70 plus 2 times age. Administer an IV fluid bolus to help maintain blood pressure, 20 mL per kilogram. Use the syringe push method for infants and small children. You may repeat to a maximum of 60 mL per kilogram. Contact medical direction for additional fluid orders. This concludes the training module on the 2020 Vermont statewide EMS protocol update for the AEMT cardiac protocols.